This recorded lecture will be going over Chapter 11, Care of Patients with Immune and Lymphatic Disorders, in the MedSurg textbook. An immune system that functions properly creates immunocompetence. Abnormal responses of the immune system are typically the result of an infection, medical therapy, or exposure to select toxins. These abnormal responses can be divided into two basic categories: immune deficiency conditions and hyperactivation of the immune system, which includes autoimmune disorders and autoinflammatory disorders. Autoimmune and autoinflammatory disorders can be organ-specific or systemic. In immune deficiency conditions, there is an insufficient production of antibodies, immune cells, or both, and these disorders can be congenital or acquired. Prolonged stress, lack of sleep, and inadequate nutrition and exercise can also depress the immune system. Chemotherapy, viral infections, smoking, and malnutrition can lead to an acquired immune deficiency. Autoimmune diseases and disorders involve the overreaction or hypersensitivity to antigens from the external environment. This causes the body's immune system to be unable to tell the difference between self and non-self. Autoinflammatory diseases have similar features to autoimmune diseases. In autoinflammatory diseases, the tissue damage is caused directly by the innate immune system cells. There are two forms of immune deficiency: primary and acquired. In primary immune deficiency disorders, the cause is an inherited genetic mutation. Approximately 500,000 Americans have some form of a PIDD, and approximately 15% of those are severely affected by it. Patients with this type of disorder experience repeated infections that clearly increase their risk of morbidity and mortality, as well as the cost of healthcare. Acquired immune deficiency disorder can result from medications such as immunosuppressants that are used to prevent tissue or organ transplant rejection, or chemotherapeutic agents to treat cancer that temporarily reduces the ability of the bone marrow to produce white blood cells. Acquired immunodeficiency syndrome is perhaps the most commonly known disorder that is caused by HIV. Chemotherapy, viral infections, smoking, and malnutrition can lead to an acquired immune deficiency. A variety of disorders or conditions can be treated or controlled by medications or therapies. Some treatments can lead to chronic medical conditions or iatrogenic complications. These are considered side effects of medical treatment. Drug-induced immunosuppression is often referred to as therapeutically induced immunosuppression. This requires a delicate balance between the control of the body's immune response and the side effects. An example of an iatrogenic immune response would occur with an organ transplant recipient. Lifelong immunosuppressive therapy will not eliminate the danger of organ rejection or other healthcare complications, and these drugs must be adjusted according to the systemic and immune responses of each patient to prevent toxicity. There is significant evidence that the use of anti-rejection medications will increase the survival rate of patients with certain organ transplantations. The immunosuppressive agents are also helpful in the management of autoimmune disorders, such as multiple myeloma, non-Hodgkin's lymphoma, rheumatoid arthritis, and certain neoplastic growths. In the early stages of an immune deficiency disorder, definitive diagnosis can be difficult. In some types of immune deficiency, passive immunity can be accomplished by transfusing specially sensitized lymphocytes to help the patient resist infection. Immune globulin is a blood product that can be given for the treatment of primary immunodeficiency diseases and certain other diseases in which antibody levels are low or dysfunctional. When impaired function of the bone marrow is involved, such as in leukemia, the patient may receive a bone marrow transplant to provide the stem cells that will eventually become immune bodies. As soon as an infection is evident, antimicrobial agents are usually given. Treatment in an immunocompromised patient is aimed at controlling the disease or eliminating the condition that led to an inadequately functioning immune system. When an immune deficiency is suspected, information about the current physical status of the patient, including general state of health, any recent infections, how frequently they occur, and what symptoms were there, should be collected. It is also essential to assess for risk behaviors such as IV drug use, multiple sexual partners, exposure to HIV, immunosuppressive drug therapy, alcohol consumption, and a family history of genetic immune disorders. Physical assessment should include palpation of superficial lymph nodes in the neck, axilla, and groin to detect any abnormalities, as well as assessing the body systems involved in the patient's chief complaints. Body temperature should be closely monitored for any significant changes, although immune-deficient patients may not have a temperature elevation even in the presence of an infection. Therefore, you must assess the whole patient because important signs or symptoms of potential complications could be easily missed if the assessment is not performed correctly. Psychosocial problems will often accompany physical problems. The primary nursing goals when caring for a patient with an immune deficiency are to protect the patient from infection, to improve the health status, and to promote a high degree of wellness as possible. Planning care for the patient with an immune deficiency will focus on preventing exposure to pathogens. A patient whose immune deficiency is severe will likely need to be placed in protective isolation precautions. It is also important to teach patients with immune compromise the actions that should be taken once they are discharged from the hospital to prevent the onset of infection. Proteins are needed to synthesize antibodies. If a patient has a condition or is taking medications that suppresses the appetite or causes nausea, nutritional intake could be inadequate. Nutritional supplements may be added, and multiple small meals of high-protein foods chosen by the patient might need to be scheduled throughout the day. Providing low-calorie snacks, such as cooked vegetables and fruits, instead of high-calorie chips, sodas, and cookies, could be helpful if the patient is trying to control overeating or they're carefully monitoring for weight gain. Excessive stress can further depress immune function. Collaboration with a social worker is often indicated. Referrals to community resources can greatly assist the patient and family in dealing with this added stress. Providing instruction regarding the immune disorder, any therapies recommended for the patient, and any follow-up care is an essential nursing intervention. You should teach the patient and family to assess for signs and symptoms of infection and then report them immediately. For evaluation, check laboratory test results to assess whether the immune function is improving. HIV/AIDS is one of the most commonly known immune deficiency disorders. Today, there is still no cure, but there are now more than 40 medications approved by the US FDA to treat HIV/AIDS. If patients who are HIV positive are compliant with their HIV treatment, including routine testing to monitor their overall health status and manage the side effects of the chronic disease, HIV can be controlled in AIDS with a good quality of life maintained. There are two forms of HIV infection. HIV-1 is the most common form in the United States, Europe, and Asia. Worldwide, about 95 cases are HIV-1. HIV-2 is widespread in West Africa. Research shows that HIV-2 spreads at a lower rate, has a lower plasma viral load, and takes longer to incubate, and individuals with this strain will have a lower risk of developing AIDS. HIV-1 and HIV-2 are retroviruses that have only ribonucleic acid or RNA as their genetic material. A retrovirus differs from other viruses because it has an enzyme called reverse transcriptase. This helps the virus replicate and place its genetic material in the DNA of the actual host cell. HIV primarily attaches to the CD4 cell wall receptors. These can be found on lymphocytes and some monocytes. Once infected with HIV, the host cell and the ability of the cell-mediated immune response is seriously impaired. Overall, detection of the infected person's blood would take about 10 days for HIV RNA and about 25 days for HIV antibodies. An individual affected with HIV will become more prone to opportunistic infections. These would include infections derived from normal flora found in the body. The diagnosis of AIDS is usually made when an HIV-infected patient's CD4 T lymphocyte count is less than 200 cells, or when a specific OI is diagnosed. The only mode of transmission is by exposure to HIV-infected blood, body fluids, or tissues. Any break in skin or mucous membranes is an entry portal for HIV. The highest risk factors for becoming infected with HIV are having unprotected sex, sharing needles and syringes with an HIV-infected person, and maternal fetal exposure. 1 in 7 people are unaware that they are infected with HIV. It is estimated that more than 50% of HIV-positive adolescents are unaware of their diagnosis and are therefore not being treated. In a CDC report that looked at data for 2015, the largest proportion of new cases, about 68%, was found to be in men who have sex with men. The second highest rate of about 23% of new HIV-positive cases was found in the heterosexual population, especially among those involved in high-risk behaviors. Participating in unprotected anal intercourse with an HIV-positive partner will increase the risk of exposure due to the microscopic tears that can occur in the lining of the anus during sex. Current CDC guidelines recommend the use of Truvada or Descovy in combination with safer sex practices for pre-exposure prophylaxis, or PrEP. Daily oral PrEP has been shown to be safe and effective in reducing the risk of acquisition for HIV-1. Before starting PrEP, acute and chronic HIV infection must be excluded by symptom history and HIV testing. Patients should be taught that a prescription for oral PrEP must be taken daily and not just coitally timed or taken intermittently. Research has also found that post-exposure prophylaxis, or PEP, is most likely to be effective when the exposure is a single episode, such as unprotected sex with an HIV-positive partner, and the PEP is initiated less than 72 hours after exposure. PEP is not appropriate for cases of multiple unprotected sexual exposures or frequent IDUs. Barrier protection must be practiced with every sexual encounter to prevent transmission of HIV or other infectious diseases. Latex condoms are more impermeable than any other type of condom. Condoms should not be stored in wallets, glove compartments, or hot or sunny areas because the temperature will degrade the integrity of the condom material. The only guaranteed way to prevent sexual transmission of HIV is through abstinence. Another unsafe practice is orogenital or oroanal stimulation without a barrier. Direct contact with any bodily fluids, such as semen or vaginal secretions and blood, must be avoided when the partner has HIV. It is important to note that if 2 people with HIV have sex with each other, condoms should still be used because one partner may have a drug-resistant strain of HIV and can then transmit that resistance to their partner, therefore increasing the risk of failed drug therapy for their partner's HIV infection. According to the American Red Cross, the current risk of contracting HIV from receiving a blood transfusion, blood products, or a donated organ is extremely small, about 1 in 2 million. HIV mutates rapidly, and countless mutations have been found, making it difficult to develop a vaccine against HIV. A nurse can contribute to the prevention of HIV and AIDS by obtaining accurate facts and educating others, including patients, colleagues, and the community, about individual roles in helping prevent the spread of HIV, as stated in the Healthy People 2030 objectives. HIV has variable clinical presentations and latent periods without obvious symptoms. Often the initial signs and symptoms of infection are similar to the flu. This would include fever, fatigue, diarrhea, and a loss of appetite. These symptoms can be ignored until the immune system begins to fail. This can be evidenced by the symptoms related to OIs. These would be considered sentinel infections, such as oral thrush, recurrent infections, skin disorders, night sweats, swollen lymph glands, and significant unintended weight loss. It is usually at this point that a person will seek health care. Testing is available through a healthcare provider, local public health clinic, community agency, or home test kit. These kits allow a person to anonymously perform the test and obtain the results in their own home. Initial testing is done by an antigen-antibody immunoassay that detects HIV-1 and HIV-2 antibodies. It is estimated that 15% of HIV-infected patients are either unaware of their infection and thus may be unintentionally infecting others. This is one reason why the CDC recommends that any sexually active person between the ages of 13 and 64 years old be offered HIV testing at the time of a complete physical examination. The results of HIV antibody tests are confidential patient information, and they are protected by HIPAA. If the patient elects to opt out of HIV testing, a note about the declination should be documented in the medical record. When an individual is confirmed to have HIV, a comprehensive history and physical examination for health status should be conducted. This should include additional baseline laboratory and diagnostic studies. A CD4 lymphocyte count should be performed, and if the count is less than 350 cells, it is recommended that the patient initiate antiretroviral therapy and the prophylaxis for OIs. Choice of optimal therapy is based on clinical data and individual factors. This would include past health status, medication history, quality of life issues, and patient expectations of therapy. The World Health Organization has established standard criteria for staging the HIV infection. The most effective current treatment is ART. This is a combination of available drugs recommended for HIV. Regardless of the medications prescribed, it must be stressed that the more compliant the patient is with the proposed treatment regimen, the less likely they are to experience any OIs. OIs are opportunistic diseases caused by microorganisms that are commonly present within the environment or the body and will only cause disease when there is a weakened or suppressed immune system. OIs are often the hallmark of a transition from HIV infection to AIDS. Effective ART can prevent HIV from depleting the immune system, allowing the body to fight off infection and resulting in fewer OIs. Acute HIV infection develops within 2 to 4 weeks and may produce flu-like symptoms in some people. During this stage, the HIV level in the blood is very high and can be transmitted to others. Chronic HIV infection is the second stage. This can also be called a symptomatic HIV infection because most people will not have HIV-related symptoms. Even though they are asymptomatic, they are still able to spread the virus. The third stage of HIV infection is AIDS. This is considered the terminal stage of the disease. The virus severely damages the immune system, and OIs and cancers occur frequently. Without treatment, life expectancy is about 3 years. Kaposi sarcoma is one of the most common causes of malignancy in HIV-positive people. KS does not usually cause death. KS appears as discolored areas on the skin, but can also form inside the mouth, lungs, and intestines. ART has been shown to halt or even eliminate the progression of skin lesions in some individuals and has decreased the incidence of KS. Lymphomas are tumors of the tissues and cells of the lymphatic system. Non-Hodgkin lymphoma, or NHL, is the most common lymphoma in people with HIV and AIDS. Cognitive disorders can occur when HIV infection enters the central nervous system. HIV encephalopathy, AIDS dementia, and AIDS dementia complex are the terms used to describe the changes in cognitive function characterized by dementia that will occur with HIV and AIDS. These symptoms have a very subtle beginning and are difficult to differentiate from depression, Parkinson's disease, and Alzheimer's disease. Nursing interventions would focus on preventing the individual from doing harm to self or others and ensuring that their daily needs are met. The assessment should include a review of signs and symptoms, a functional level of ability, their safety, self-care abilities, support systems, financial status, risk behaviors, living environment, and understanding of the disease process, transmission, and therapeutic regimen. The assessment of the functional level is an ongoing assessment using a tool known as the Karnofsky Performance Status Scale. Previous history of HIV testing, such as blood donations or military service, may be important for determining the timing of HIV infection. If the patient has been HIV positive for some time, it is important to obtain a history of any OIs. Also assess for any smoking history. The neurologic history should include questions about pain or numbness in the extremities, as well as changes in mental status. A sexual history is needed to ascertain risky behaviors, such as multiple sex partners, possible exposure to other sexually transmitted infections, and a history of substance use to determine the risk of transmission. Discussing notification of sexual or needle-sharing partners is essential, and a complete head-to-toe physical assessment should be performed. When there is considerable weight loss, referral to a nutritionist or dietitian and providing written materials, such as how to plan a nutritious, balanced diet, can be very helpful. It is important to determine whether the patient has told their family of their HIV status. Referrals are needed if the patient does not have a support network. A patient who is HIV positive can have significant issues related to finance, employment, housing, mental health, substance abuse, or other mental problems. HIV care is usually performed in an outpatient clinical setting, and the healthcare team may include the patient, nurse, healthcare provider, dietitian, pharmacist, case manager, and primary caregiver at home. If the patient is able to have a role in decisions and adjustments to the treatment plan, it will increase the likelihood of their compliance. Encourage social interaction and independence in activities as tolerated. Support groups can boost feelings of self-esteem and self-worth. Referral to a community-based HIV/AIDS organization is appropriate, of course with the patient's consent. Hand hygiene is critical for healthcare providers, the patient, and the family to prevent secondary infections. You must also teach about decreasing infection risk within the home setting. Monitoring laboratory tests to determine immune status, viral load, blood cell status, and the effects of medications is a large part of the evaluation process. The life expectancy in the United States has increased to greater than 78.8 years, and that is expected to continue to increase over the next several decades. People aged 50 years and older constitute about 45% of Americans diagnosed with HIV. Many older adults are not aware of the risks, but old age is not a barrier to becoming infected with HIV. Injection drug use is another source of infection. An older adult may ignore symptoms due to a belief that they are part of the normal process of aging. By the time an older at-risk adult patient is diagnosed, the survival rate is markedly less than that of a younger person. Menopausal women are more vulnerable to HIV infection from sexual transmission due to decreased estrogen levels causing thinning and decreased lubrication in the vagina. Educate this age group about the need for HIV testing in both partners before entering into a new sexual relationship and provide recommendations about using barrier techniques. All medical information is protected under HIPAA guidelines. Many states have additional requirements when disclosure of HIV status or AIDS diagnosis is involved. For the patient, the consequences may be the loss of a job, housing, or insurance benefits, and possible discrimination and rejection by family and friends. The CDC and OSHA, along with other healthcare agencies, have developed evidence-based guidelines to prevent exposure to blood, body fluids, and other potentially infectious material. All facilities have mandated training to make their staff aware of guidelines and promote workplace safety. Autoimmune and autoanti-inflammatory disorders are caused by the immune system reacting against the body's own cells. The three categories are classified according to how extensively the disorder affects body tissues. It can be local, affecting only a single organ or tissue, systemic, which affects many organs or tissues, or mixed, localized, and systemic, which causes problems both in localized areas and systemically. Autoinflammatory disorders are caused by a malfunction in the innate immune system, and autoimmune disorders are caused by problems in the adaptive immune system. In autoinflammatory diseases, the innate or natural immune system reacts with no reason and without control. This inflammatory process will produce fever, and at many times it is the result of a genetic mutation. Autoinflammatory diseases are rare and would include conditions such as familial Mediterranean fever. In autoimmune diseases, the adaptive or acquired immune system is responsible for identifying and eliminating foreign threats. In autoimmune disease, the body does not recognize its own tissues as self, but as a foreign threat, so that the immune system is activated and destroying cells identified as a threat. Autoimmune conditions are fairly common, and significant research has been conducted to identify best treatment options. Not all experts agree, but at this time, more than 100 diseases are thought to be triggered by an alteration in immune function. General signs and symptoms would usually include fever, fatigue, abdominal pain or digestive issues, swollen glands, joint pain, and swelling. Diagnosing an autoimmune and autoinflammatory disorder can be difficult. The most commonly occurring conditions consistent with the presenting symptoms are ruled out first. It is usually after other diseases are ruled out that more in-depth genetic and other testing can be done. This can be frustrating for a patient who has not felt well for some time and is just looking for an explanation or diagnosis. Blood tests such as a CBC with differential is typically performed. Other laboratory tests evaluating inflammation, such as an ESR and CRP level, are not specific to immune disorders, but they may help confirm the diagnosis when used with other information. For disorders that are organ-specific, a biopsy of the affected tissue may be used to confirm or exclude the diagnosis. For autoinflammatory disorders, genetic testing may be performed. Treatment falls into two categories: replacement or support of lost or ineffective body function, or therapies targeted to halt the destructive process. The goal of physical, occupational, speech, or even psychological therapeutic interventions is to help the patient learn how to effectively deal with their disorder and be able to function at the highest achievable level for as long as possible. Systemic lupus erythematosus is also known as lupus. It is an autoimmune disease. The term erythematosus refers to the erythema that often accompanies the disease. Genetics, hormones, immunologic response, and environmental influences may play a role in the development of this disease. However, no specific link has ever been established. SLE has a discord form. This would affect the skin, but not internal organs. A systemic form that affects the internal organs and is the most common type, and a drug-induced form. This tends to be milder and less damaging to the body. Although SLE is incurable, symptoms can be treated. Individuals of all ages have been diagnosed with SLE, but the typical age of onset appears to occur after puberty and peaks between 15 and 40 years of age. It occurs more often in women and men, with a ratio of 11:1. SLE usually waxes and wanes throughout the course of the disease. Some individuals have a very mild form of the disorder and have infrequent flare-ups with minimal symptoms. Others have severe, debilitating symptoms that, if left untreated, can lead to death. Prolonged exposure to sunlight can initiate a flare-up of SLE, so use sunblock and covering the skin is very important. Signs and symptoms tend to come and go and would include painful or swollen joints and muscle pain, extreme fatigue, unexplained fever, red rash, usually on the face, unusual loss of hair, sensitivity to the sun, weakness and profound fatigue, mouth ulcers, poor appetite, weight loss, abnormal menses, edema, and swollen glands. Weakness is a hallmark of the SLE process. Azotemia, hematuria, proteinuria, and pyuria would indicate renal involvement involvement, such as nephrotic syndrome or acute or chronic renal failure. Neurologic symptoms may include headaches, seizures, psychosis, or other cognitive disorders. Heart failure, pericarditis, and coronary disease can also be symptomatic of SLE. Currently, no single test can confirm a diagnosis of SLE. To confirm SLE, a patient must have at least 4 of the 11 clinical presentations or laboratory test results performed for SLE. A syphilis test will measure antiphospholipid antibodies in the blood. These are known to be present in lupus, so a false positive syphilis test could be another indicator of SLE. There is no cure for SLE. Current treatments are targeted towards symptom control or management to prevent exacerbations, treat flare-ups when they occur, and minimize organ damage and long-term complications. Glucocorticoids, such as prednisone, can be taken to reduce symptoms experienced during major flare-ups. NSAIDs can be used to reduce inflammation and control pain. Immunosuppressant agents are given to suppress the immune system, thereby reducing the risk of a systemic attack. Rest, balanced diet, and exercise are also primary treatments for patients with SLE. Assessment of the patient's ability to participate in ADLs is important. Joint pain is common, and management of that pain and assisting with mobility should be a priority. Educate the patient about their disease and how to prevent any possible complications. Infections can also exacerbate symptoms, so the patient should avoid being around anyone who is showing signs and symptoms of a communicable disease. On page 239, see the blue patient teaching box for skin protection for patients with SLE. They should apply non-perfumed lotion liberally to dry skin areas at least twice daily. Lymphoma is a form of lymphatic cancer that starts in the lymphocytes. The 2 main types of lymphoma are Hodgkin lymphoma and non-Hodgkin lymphoma. The primary differences between the two are the types of lymphocytes involved in the disease. There are 2 main types of HL, classical HL and lymphocyte predominant HL. Classification and staging of these 2 diseases is complicated. It relies heavily on microscopic examination of tissues and diagnostic studies. This would include serum blood testing and select types of scans to determine the type and the true extent of the disease. HL is known as Hodgkin's disease. The cause of HL is not known, but there are possible genetic and environmental components that in combination can initiate the onset of the disease. Studies have shown that there is a 10 times higher risk of developing the disease in same-sex siblings of patients with HL. An association has been found among patients with HL who had few or no siblings, lived in a single family home, who were early in the family's birth order, and had few playmates. This form of life environment will tend to decrease exposure to infectious agents at an early age, so the immune system is not exposed to as many microorganisms, and therefore fewer antibodies are produced. The B cells in the immune system begin to develop atypical cells. The disease spreads from one area to another via the lymphatic system and can then invade other body systems. More than 80% of cases will present with lymphadenopathy, which is enlarged lymph nodes. These will be found above the diaphragm. The patient may also complain of abdominal fullness, fatigue, profuse night sweats, unintentional weight loss, and pruritus. High suspicion for HL exists when the patient has complaints of swollen lymph glands lasting for several weeks and no recent history of any type of infection. A definitive diagnosis for HL is confirmed by the presence of RF cells in the tissues obtained by biopsy of the lymph nodes. Radiographs, CT, PET scans, and bone marrow biopsy can also be used to help determine the extent or stage of the disease. Treatment would depend on the stage of the disease and whether involvement is above or below the diaphragm or both. Once the stage is known, the absence or presence of one or more of the following symptoms is noted. any unintentional weight loss of more than 10% of body weight over the past 6 months, an unexplained fever greater than 100 degrees for 33 days or longer, profuse night sweats not related to weather conditions. In patients with 4 or more involved nodule areas who are older than 50 years old and who have an ESR greater than 30, the outlook is less favorable. Chemotherapy can be given in all stages of the disease. Once it is completed, a more precise form of radiation therapy, called involved node radiotherapy, could be considered. Stages 3 and 4 disease show better improvement with meclorathine, vincristine, procarbazine, and prednisone in combination with ABVD therapy. The number of cycles of chemotherapy will depend on the stage of the disease, the response of the patient to the therapies, and whether a relapse occurs. Stage 2 Hodgkin disease means that there are 2 nodes in the same area infected. Patients may experience complications from HL and the treatments. Examples of some of the adverse effects include permanent sterility, temporary hair loss, subclinical hypothyroidism, and an increased risk of developing cancer in other organs years after completing radiation therapy. Nursing care should focus on symptoms of the patient that the patient is currently experiencing and the side effects of the prescribed therapies. Prevention of healthcare-associated infections is essential. Non-Hodgkin lymphoma, or NHL, accounts for 4% of all cancers in the United States. It is the 7th most common cancer in men and women. The median age of diagnosis of NHL is 50 years of age. The overall rise in incidence is believed to be related to the continued advances in the successful diagnosis and treatment of a variety of diseases. NHL is similar to HL, but NHL is less predictable and tends to spread to other body sites much more rapidly. Only biopsy of pathologic lymph nodes and tumor tissue can provide a definitive diagnosis of NHL. There are several types of NHL. One type is an indolent, slow-growing form in which symptoms are usually not present until the advanced stage of the disease. The other forms of NHL are more aggressive. If treated with intensive chemotherapy, there is a survival or cure rate of 70% at 5 years and 60% at 10 years. The rate of cure is reduced if NHL is diagnosed in a late phase. 5 risk factors include disseminated tumors, elevated levels of lactate dehydrogenase, poor functional ability of the patient, an age older than 60 years old, and disease that has spread beyond the lymph nodes. These can be used to predict the outcome of patients with more aggressive forms of B-cell lymphoma. This is the most common type. Having none or one of the risk factors would suggest a good outcome, but having 4 or 5 indicates a poor prognosis. When relapses occur, they typically do so within the first 2 years after treatment. Unlike HL, NHL typically shows up in one node. Then, 1 or more nodes are skipped, and then another node is affected. This is referred to as non-contiguous. NHL usually manifests as a unilateral painful enlargement of a lymph node that may progress to a generalized painless lymphadenopathy. NHL tumors can occur in the brain, respiratory system, spleen, GI tract, bone, or other parts of the body. Symptoms related to other organs are site-specific and can include complaints of high fevers, chills, drenching night sweats, unexplained weight loss, cough, dyspnea, chest pain, nausea, vomiting, a sense of fullness in the abdomen, and constipation. Laboratory tests can show elevated liver enzymes. Physical examination can reveal a change in level of consciousness related to an increase in intracranial pressure. This is especially true in patients with aggressive NHL. The effectiveness of treatment will depend on the stage of the tumor at the time of diagnosis and the type of lymphoma, whether it's indolent or aggressive. To aid in staging, CT, MRI, PET, or ultrasound can be used to determine the extent of tissue involvement and to assess therapeutic responses after therapy has been completed. Biopsy of various body tissues can also be performed in one of 3 ways to determine the type of the NHL. It can be an excisional biopsy, in which an entire node is removed, an incisional biopsy, in which only a piece of the node is removed, or a fine needle aspiration, in which a needle is used to aspirate tissue from the mass of cells. Treatment can be given with chemotherapy or irradiation, depending on the stage of the disease. Stage 1 or 2 or low-grade NHL can be cured with radiation therapy alone. Bone marrow transplantation, autologous stem cell transplantation, and immunotherapy with monoclonal antibodies are possible treatment options. Surgery can be attempted if the tumor is localized or as palliative care. Vaccines for this disease are currently in clinical trials. Nursing care is directed towards supporting the patient through the diagnostic procedures and observing for and treating any side effects of radiation and chemotherapy. When the lymph system is unable to circulate normally, large amounts of fluid will accumulate, known as lymphedema. This causes swelling. If this is not controlled, the swelling can lead to further damage to surrounding tissues, nerves, and blood vessels. There are two types of lymphedema, inherited and acquired. The inherited form, or primary, is a congenital condition in which there is a deficient growth of the lymphatic system, especially in a lower extremity. This condition would chiefly affect women and most often becomes apparent during the middle teens to 20s. The acquired form, or secondary, typically results from an obstruction caused by trauma to the lymph vessels and nodes, such as occurs during a mastectomy when lymph nodes are removed, after radiation therapy, or after a liposuction procedure where some of the lymph nodes may have been damaged. Patients may have a variety of symptoms, including restricted range of motion, heavy feeling, aching, discomfort, recurrent infections, and thick, hard skin. Regardless of the cause, treatment goals are to minimize the effect of the disease and process on the individual. Lymphedema of an extremity often can be treated conservatively through light aerobic exercise and by using simple nursing measures. For example, the patient can be taught to wrap the extremity with an elastic bandage, beginning at the most distal portion and working up the extremity. The compression bandage can help minimize the degree of lymphedema. Elevation of the affected extremity is also recommended, and meticulous skin care will be needed to prevent cellulitis. There is no cure for this condition. Measures to manage lymphedema are lifelong. Prevention and treatment of lymphedema will be discussed more in Chapter 39. In the 1970s, fibromyalgia was identified as a condition of chronic systemic pain and multiple symptoms that could not be explained as caused by any specific source or disease. The condition is still not fully understood. It is considered a problem with pain regulation and classified as a disorder of central sensitization. This disorder affects 10 million people in the United States. Of the 10 million people affected, 75 to 90% are women between the ages of 20 and 50 years old. The most common feature of this disorder is musculoskeletal pain. It is typically described as a diffuse or multifocal pain with flare-ups and remission, along with migration from one area of the body to another. Chronic fatigue syndrome, irritable bowel syndrome, sleep disorders, and inflammatory rheumatic disease have all been associated with fibromyalgia. Patients typically have either hyperalgesia or allodynia. Allodynia is a pain response to non-painful stimuli. There is no specific diagnostic test that can confirm the diagnosis of fibromyalgia, so treatment will focus more on symptom relief. Currently, there are 3 medications approved by the FDA that help with pain management: the anti-seizure medication Lyrica, the antidepressant Cymbalta, and Savella. Low-dose antidepressants that can also be used would include tricyclics, selective serotonin reuptake inhibitors, and benzodiazepines. Additional treatment is based on the symptomology and could include light exercise, massage therapy, guided imagery, dietary changes, and referral to a mental health provider. Intervention should focus on helping the patient to manage their fatigue, pain, activity intolerance, sleep disruption, and stress. The family should be included in the education process. An allergy is an abnormal response to certain substances. It is considered a systemic immune disorder rather than a local one, and the reaction can be seen or expressed in one or more body systems. Hypersensitivity reactions, better known as allergic reactions, are the body's excessive response to a normally harmless substance. The severity of this condition can range from a mild rash to anaphylaxis. Exposure to microbes and illnesses can build up the immune system, and sanitizing the environment does not allow for these opportunities. Changes in lifestyle and environmental exposure, rapid urbanization, altered diet, and antibiotic use have had a profound effect on the human microbiome, leading to failure of immunotolerance and increased risk of allergic disease. Complex hereditary, environmental, and site-specific factors will contribute to allergic reactions. Hypersensitivity reactions can be divided into 4 types. Type 1 is an immediate hypersensitivity reaction. This involves immunoglobulin E, mast cells, and eosinophils. Type 2 is an antibody-mediated reaction. This involves immunoglobulin G or M, attaching to the cell surface of antigens. Type 3 is an immune complex-mediated reaction. This involves bound antigen-antibody complexes being deposited in the tissues, causing inflammation and tissue destruction. Type 4 is a T-cell mediated or delayed hypersensitivity reaction. This involves cell-mediated immune reaction rather than antibodies. As with all types of normal and abnormal immune responses, a reaction will not occur until an individual's body cells have been sensitized to the specific substance that triggers the response. When histamine is released because of an immune response, it triggers increased mucus secretions, vascular permeability, and vasodilation. These lead to tissue edema. If the mast cells are IgE dependent, they typically produce only a localized allergic response. The body system most often affected by the offending agent may present more specific symptoms. Should the allergen be inhaled, the release of histamine can cause the contraction of smooth muscle tissues in the bronchioles of the lungs. Identification of allergens can be a tedious process. You should ask about exposure to substances that appear to have or are known to cause an adverse response. The two primary methods used to test for allergies. There are 2 primary methods used to test for allergies. One is performing a radioallergosorbent test known as a RAST. This test uses a blood serum from the patient to determine whether the IgE to the suspected allergen is present. The disadvantages to the RAST are that it's more expensive than skin testing. It can take several weeks to days before the results are known, and it's less specific. This means the test will tend to produce more false positive and false negative results to allergens. The skin scratch test has been the most reliable method of allergy testing for more than 100 years. The patch test is similar to the scratch test, except that the allergen is placed on the surface of the skin and covered with an airtight dressing or patch. A patient may have a confirmed allergy to a medication that is required and for which there are no alternatives. Steroids, antihistamines, or other immune response regulating medications can be given prior to giving the medication. You should stay with the patient and closely monitor them for any signs and symptoms of a reaction during this process. Resuscitation drugs and emergency equipment should be immediately available. If it is known in advance that the drug will be needed, the patient can be desensitized to the drug before it is used. Even though other diagnostic methods are available to test for food allergies, a less expensive approach known as the elimination diet should be tried first. Tell the patient to eliminate one food at a time and keep a detailed diary, recording everything ingested each day, including additives and preservatives in each food product. If symptoms persist for a week to 10 days after eliminating one food product, the patient can resume intake of that food and then choose another one for elimination. This process should continue until the offending food source has been identified. Assess each patient for a latex allergy because the presence can change the method of care delivery. Most patient care items, including gloves, Foley catheters, surgical drains, bandages, and condoms, are now latex-free. Drugs that help alleviate systemic reactions to allergens include epinephrine, antihistamines, bronchodilators, corticotropin, and cortisone. Cortisone. Antihistamines will help control the symptoms of hay fever and hives by preventing the release of histamine during an allergic reaction. Diphenhydramine is commonly used orally and topically to counteract many allergic symptoms. Antihistamines can cause drowsiness and impaired coordination, so there are restrictions on driving automobiles and operating machinery at the beginning of therapy. Other common side effects would include dry mouth, urinary retention, weakness, and blurred vision. Anti-inflammatory drugs such as corticotropin and cortisone are administered to reduce the inflammatory response that occurs in an allergic reaction. If the respiratory tract is involved, bronchodilators can be given to help relieve dyspnea and wheezing. Local reactions involving widespread and deep skin lesions can be treated with salves, such as calamine lotion, wet compresses, and soothing baths. When exposure to allergens cannot be avoided, or if the symptoms cannot be managed successfully, desensitization may be suggested. The purpose is to decrease sensitivity to allergens. Regular injections of extremely small quantities of selected antigens are given daily, weekly, or monthly. The amount given is gradually increased until there is a noticeable clinical improvement, and then a maintenance dosage is given. The program can last for years, but improvement should be noted about 6 to 24 weeks after it begins. Removal of carpeting, routine cleaning, as well as daily dusting and vacuuming, and eliminating of dust-harboring furnishings can help remove allergens. Electrostatic filters with HEPA filters are essential for those with severe inhalant allergies. Molds can grow in moist environments, so basements, building foundations, showers, and bathing areas are typically prone to mold growth. Routine cleaning and adequate ventilation can help reduce or eliminate mold growth in most homes. Patients with allergy-induced skin conditions should be taught that a warm environment and sweating will increase the sensation of itching. Avoiding exposure to allergens will require knowledge of the nature of the allergen, method of transmission, source of the reservoir, and a portal of entry. Anaphylaxis is a serious, life-threatening, whole-body allergic reaction. Any agent that causes a severe hypersensitivity reaction can cause anaphylaxis. For anaphylaxis to occur, the allergen usually needs to be delivered systemically before the sensitized mast cells are triggered to react. Histamine will cause a dilation of small blood vessels, a pooling of blood, and a release of fluid into the tissues. This can lead to circulatory collapse and profound shock. A less severe reaction usually occurs if the allergen is delivered by direct contact, inhalation, or ingestion. IgE-mediated immune responses typically require repeated exposures for reaction to occur. In the non-IgE allergen response, a single encounter can lead to anaphylaxis or even death if not recognized immediately. Nurses must be alert for previous allergic reactions and identify patients who are likely to experience a serious reaction. Before administering any medication or drug, you must verify the patient's known allergies. The National Patient Safety Goals views this as a safety measure. You should check all areas in the medical record for where allergies are usually documented. An anaphylactic reaction requires immediate action. The appearance of hives or urticaria, or swelling beneath the skin, can signal the onset of an anaphylactic episode. Hives or sudden outbreaks of wheals on the skin that itch and burn can appear without subsequent anaphylaxis. Tachycardia, decreased pulse, and a rapid drop in blood pressure will signal circulatory collapse. This can occur very rapidly. The patient will also exhibit increasing dyspnea due to the narrowing of the air passages, accumulation of mucus, and the wheezing. If an airway is not maintained, convulsions can occur because of oxygen deprivation. Treatment must be started immediately to avoid hypoxic brain injury or death within a matter of minutes. Emergency supplies should be readily available whenever vaccines, serum for passive immunization, and highly allergic drugs are administered. Pre-medication with steroids or antihistamines can be administered if a substance that the patient has shown sensitivity to in the past must be given. There is no test to confirm the diagnosis of anaphylaxis. Rather, it is the presenting symptoms, including sudden onset involving one or more body symptoms, producing one or more symptoms such as itching, hives, stridor, wheezing, or shock, that confirm the clinical diagnosis of anaphylaxis. Treatment of anaphylaxis includes the following: establishing a patent airway and administering oxygen, administering IV epinephrine to counteract the effect of histamine, relax the bronchioles, increase cardiac output, and elevate blood pressure. Administer antihistamine. Institute measures to prevent or control shock. Provide psychological support. When there is difficulty with breathing because of swelling in the airway, you should provide high-flow oxygen. Epinephrine is given to counter the allergic reaction. It can be given IV, IM, sub-Q, or through an established ET tube. IM injection is the preferred route of administration in the initial phase of the reaction. If IV administration is required, it should be given as a drip. If the patient is taking beta blockers, these drugs can hinder the effectiveness of the epinephrine. During the crisis, vital signs and respiratory effort should be monitored continuously. Adequate pharmacologic support and IV fluids are important to maintain perfusion and an adequate blood pressure. People who have extreme sensitivities to certain allergens should carry a medical alert bracelet or medical alert card that contains their information. It is also advisable for individuals who are highly allergic to stings from bees, wasps, or other insects, or who are severely allergic to nuts or some other kind of food. They should carry an EpiPen and a small kit containing epinephrine, a syringe, needle, and tourniquet, as well as diphenhydramine hydrochloride with them at all times. They are strongly recommended by allergists because of how quickly an insect sting or inadvertent ingestion of a food can produce a fatal reaction in someone who is highly sensitive. It is also advised that the patient inform their coworkers or family members where the kit can be found should it be needed.